Hello, my name is Henry Silverman, and today I would like to give a presentation regarding truth-telling in medicine and specifically address the question, can deception ever be morally acceptable or justified in healthcare? First, let's go over some definitions. Most would agree that a lie represents saying something that is not true. In contrast, deception may include the admission or the withholding of dismal facts, but not necessarily telling an outright lie, as no untruthful statements have been made. This is sometimes framed as non-lying deception. Although not considered a lie, this concept of deception, the omission of facts, brings up the distinction between telling the truth and being truthful. Hence, while one can say that one is still telling the truth if one merely omits dismal facts, one nonetheless is not being truthful. That said, we still need to explore the ethics of non-lying deception in the practice of medicine. This slide will show the reasons given for being untruthful or lying in healthcare. First, the principle of non-maleficence or do no harm can be achieved by lying. For example, the withholding of bad news might be acceptable as disclosure can cause real and predictable harm. This brings up the concept of the therapeutic privilege, which refers to the withholding of information by the clinician in the belief that disclosure of this information would lead to emotional suffering by the patient. Examples of the therapeutic privilege includes the withholding of a cancer diagnosis from patients or the withholding of any type of bad diagnosis from a psychological fragile person. Those who believe that there might be a role for the therapeutic privilege in medicine also caution that it must not be abused. Second, the principle of beneficence, or doing good for patients, may also justify deceptions. Examples would include the deceptive use of placebos and also lying for patients on disability forms and health insurance forms. In the latter two instances, one must balance this principle of beneficence for patients against that of justice, as lying for patients on disability forms and health insurance forms while providing extra benefits to individual patients does financial harm to the general population. Finally, deception can respect autonomy if one reliably knows that the patient prefers not to be told the truth. In contrast, several reasons can be given as to why lying is morally incorrect. First, if found out, it will diminish the trust that society has for the medical profession. Second, it demonstrates a lack of respect for persons. And finally, deception can diminish autonomy if patients desire the whole truth so that they can make informed decisions. When one invokes the therapeutic privilege to justify deception, one is using a form of paternalism that is referred to as weak paternalism. But weak paternalism occurs when a patient lacks important dimensions of capacity to make autonomous decisions or to handle the truth. This occurs in the case for a child, an elderly patient with dementia, or anyone who suffers from mental illness. Weak paternalism is generally easier to justify than its cousin, strong paternalism. Strong paternalism occurs when a patient has full capacities for autonomous decision-making, but the provider nonetheless feels that the patient's decision is mistaken and will cause great harm to him or herself. Accordingly, the provider entertains the idea of making the decision for the patient. Strong paternalism is seen as much harder to justify as it represents a threat to respect for autonomy. As such, it is never justifiable in the doctor-patient relationship. This slide will show a test or an algorithm to consider when one contemplates using deception. First, one should consider whether there are some truthful alternatives to deception that can achieve the same purpose. Next, one needs to determine the moral justification for the deception. Examples include to prevent psychological harm, the patient cannot cope with the truth, the patient is believed to not to want to know the truth, and finally, that deception will enhance autonomy for the patient in the future. Subsequently, one should also consider the objections against deception. For example, if discovered, there will be emotional distress or loss of trust. Deception poses a threat to enhance patients' immediate autonomy, and deception represents a violation of the norm of honesty. After this reflection, one should determine whether the justifications outweigh the objections. Finally, one should ask whether one will be able to defend the deception to a professional body or public jury of reasonable persons. I would now like to discuss the situation in which deception or the withholding of the truth commonly occurs in the practice of medicine, as exemplified by the following case. Mrs. Lee is an 80-year-old Asian widow who is hospitalized with weight loss, generalized weakness, and a pulmonary mass. The workup reveals that she has cancer. Her oldest son approaches the physicians and asks that the patient not be told the diagnosis, stating that in their culture, the elderly are protected from such distressing news. In mainland China, cancer is considered fatal, and to tell her would be like giving her a death sentence. Should you respect the son's request? This slide shows the results of previous surveys documenting the frequency with which physicians would not give their patients the truth about their cancer diagnosis. In 1961, 90% of physicians would not tell patients their cancer diagnosis. However, when the same survey was conducted in 1979, 98% of the physicians said that they would tell. The reason for the shift in attitudes include: 1, better training for physicians in the care of the dying patient. 2, legal requirements for informed consent. Social trends that include consumer activism. And finally, therapeutic advances in the field of cancer that makes the telling of patients of their cancer diagnosis that is not considered a death sentence. Studies have shown that acceptance of non-disclosure of the truth is governed by culture. For example, Western civilization considers that autonomy is a primary principle, and hence non-disclosure is rarely tolerated. In contrast, Eastern civilizations hold an opposite viewpoint that includes 2 basic norms. First, decision-making authority lies with the family and not with the individual who is sick. Second, withholding bad news from family members who are ill is acceptable. Full disclosure violates both of these norms. So how culturally bound is the current Western emphasis on autonomy and hence the need to tell the whole truth to the patients? Only a tiny slice of the entire history of medicine is dominated by an autonomy ethic of truth-telling. The majority of other cultures still seem reluctant to embrace such an ethic. Studies have shown that people from many different cultures are more likely to believe discussing death can bring death closer. This has been particularly seen among African Americans, some Native American tribes in the U.S., and among individuals from China, Korea, Mexico, and the Middle East. This slide shows the results of a study looking at 800 patients in the Los Angeles area, 200 in each of the 4 different ethnic groups: African American, European American, Mexican American, and Korean American. It shows dramatic cultural differences in attitudes about whether a patient should be told that they have a diagnosis of cancer. For example, more than 90% of African Americans and those of European American descent believe that patients should be told of their cancer diagnosis, whereas lower percentages among those of Mexican and Korean descent held such an attitude. That said, For sure, at least some traditional cultures are moving in a Western direction, for example, the Japanese. Regarding the previous case study involving Mrs. Lee, a survey was performed to determine what percentage of doctors said they would more likely abide by a family request to withhold information if they believed that such a request would respect cultural norms. And the answer was 63% of the doctors said they would honor such a request. Indeed, certain cultures are against what is called truth dumping and consider it to be a violation of beneficence, as telling the truth is usually perceived as being cruel and uncaring. However, is it not that non-disclosure is a violation of autonomy? To answer this question, many ask whether full disclosure, no matter how bad is the news, still makes the patient a better or a freer decision maker. Also, should not the patient get a voice in how the truth is told? Is there a way to respect autonomy and still prevent unwanted information from being revealed to the patient and hence respect culture? Can one advocate for a reasonable mix of beneficence and respect for autonomy? We can take some advice from Robert Buckman, who wrote a book entitled How to Break Bad News. In this book, he presents a truth protocol, which consists of the following steps. First, pick a good time and setting and assemble the right people. Second, find out how much the patient already knows. And third, find out how much the patient wants to know. Then, share the information the patient seeks in a sensitive manner and in appropriate chunks of information. Finally, respond to the patient's feelings and then plan and follow through. Lessons from Buckman include 1. Effective truth-telling is heavy on listening and light on talking. 2. Most patients want to know more and can handle it. For sure, a few don't want to know more information. Also, giving patients a greater role in setting the agenda is respectful of autonomy and is also considered compassionate and caring. It is rare that the question should be, should we tell the patient the truth or conceal it from her? It is not that black and white. Rather, breaking bad news involves a series of questions such as when to tell the patient, how much to tell, what exact words to use, whom should be there with the patient, and then what comes next. Finally, in summary, try to place the choice of disclosure with the patient. Follow patient's wishes. Abide by the family request for non-disclosure only if the patient requests that communication be through the family. Offer the truth by asking patients what they want to know, and then disclose if the patients ask. Finally, tell the truth, but as positively as one can without distortion. Thank you very much.